progressed to ARDS. Initially, there was no bacterial infection and diabetic patient, and then diagnosis. This is the X-ray. You can see basically this is the ARDS picture. And so once it's a complicated malaria, Vivax malaria, Consider negative, what treatment do you do in your eyes? Complicated Vivax. That's a Vivax with an ARDS. In your ICU, what treatment do you give to this patient?
Vivax malaria usually once present, obviously, by protocol it is chloroquine. Usually in 5x malaria, obviously primarily patient gets the chloroquine, but soon the patient gets complicated or went to ARDS or something like that. Definitely we step up the therapies and we ultimately switch the malaria treatment to artesunate intravenous, and along with other supportive measurements like management of ARDS and to pick up the any infective changes. It is an infective cause of ARDS or due to the malaria itself. If it is obviously infective, then according to the hospital-based antimicrobial stewardship program definitely come in vogue, and accordingly we start the antimicrobials, including antibacterial and antifungal as well. But the majority, in most of the cases, the treatment with artesunate IV definitely give a good result for malaria, and if it is due to the malaria, the ARDS, with time it settles.
I'll have to rush to 5 questions and ask all of you. Are you comfortable with giving artesunate only in a complicated Vivax malaria, or with the second anti-malaria drug?
Do you want to use a second antimalarial? Despite using artesunate, things are not going exactly the way you want them to be. So what do you use next?
So we use artesunate only most of the times. Only, yes, sir. I would like to go with chloroquine also.
Basically, the teaching is that if it's a complicated malaria, Vivax or falciparum, then you use artesunate. Artesunate is a very fast killer. But main problem with artesunate that there is a development of raised cells against artesunate even while in therapy. So you need to give something. When it is orally artesunate, then artemether or something, you need to give halophantrin. Similarly, when it is intravenous, we use either doxycycline or we use clindamycin. Our practice, not very strong evidence, but our practice is if there is hepatitis, we use clindamycin. If no hepatitis, we use doxycycline. This patient was given artesunate with clindamycin. She settled a bit. Then after some time, do you use routinely in complicated malarias, do you use routinely broad spectrum antimicrobial, antibacterial?
Sir, we have got some case of artesunate resistant malaria. And that case, what will be the drug of choice?
That is going to fall back to quinine, actually. So that's fine, but right now my question is, do you use an antibacterial drug, broad spectrum, in a patient with complicated malaria who has not grown anything, normal blood counts? Do you do anything like that?
No, not all complicated malarias, but here it is a ARDS. So until we are proving it is a non-infectious cause, definitely we have to add the broad spectrum antibiotic, and obviously either doxycycline or clindamycin as you mentioned. But yes, obviously you use the clindamycin, we use doxycycline more. Along with that, obviously broad spectrum antibiotic has to be added until it is proving non-infectious.
That agrees with WHO recommendation that you need to give a broad spectrum antibiotic. This patient settled somewhat, went to a pressure support ventilation, but then was found having anemia. 6.8 was the hemoglobin. Otherwise, the patient was fine, passing out urine, blood gas was normal, on pressure support ventilation. Do you transfuse the patient with blood in this patient?
So what is your transfusion trigger?
We will not transfer this patient. We will wait until the course is completed. Then we will recheck the markers. If it's not due to if the anemia is due to other causes, then we will give blood transfusion.
My question is specific. This patient has got is still on ventilator on a pressure support being weaned. At that time, the hemoglobin is 6.8. The original diagnosis was the ARDS. Do you transfuse the patient PRVC or not?
Even if it is a sepsis, the trigger is 7 gram per DL. So obviously less than 7, we have to transfuse the blood.
Guidelines are 7, but they say that you need to, not the guidelines is sacrosanct. Particularly, we are slightly scared in giving a PRVC transfusion to patients who are coming out of ARDS. Actually, that may suddenly worsen the ARDS. So here it is plus minus. Some people may prefer or some people may not prefer. The patient was weaned off, but after 2 days again required a reintubation because there was the appearance of fresh pneumonia this time with a hypoxemia. And intubated and ventilated, the culture showed that the patient grew a MBL producing Acinetobacter. So what is your treatment therapy for an MBL producing Acinetobacter? Ventilator associated pneumonia. What do you
MDR Acinetobacteria pneumonia, it is a hospital acquired pneumonia. The drug of choice is colistin is the first choice if it is the sensitive. If it is not sensitive, then we can go for TG with a cyclin or with beta-lactam, that is the carbapenem.
So we have to rule out whether the organism is carbapenem is producing. It is a carbapenem producer. If it is carbapenem producer, then we have to look for the hemodynamics. So if it is hemodynamically stable, then we'll go for the septaginic myovectum and astronum as per the genetics. Otherwise, we'll go with meropenem.
We can try minocycline in these patients in combination therapy. We can use minocycline.
Thank you. The recommendation again for this MBL, this Astronium ceftazidime does not work. Acinetobacter, it is not. You will have to give a polymyxin. We practice that if it is a pneumonia, we prefer polymyxin B, and if it's a urinary tract infection, we go for colistin. And specifically, we need a second drug possibly that can be a high dose sulbactam, 3 grams twice daily, or it can be minocycline if it is sensitive. TG cycline can also be used, but somehow right now it has fallen out of favor. People are no more mentioning much of TG cycline. So that is what we treated. We treated with sulbactam and polymyxin B, and the patient came out of this thing. But sepsis blood count were coming down. The patient remained hypoxemic, and his CT done showed that if there were extensive changes suggestive of ARDS still, the patient could not be fully weaned. So in that case, my last question is that in an ARDS, do you prefer, other than controlling infection, etc., do you prefer steroids, systemic steroids in ARDS?
There's been a lot of study on this, but in the late phase of ARDS, if you are using steroids, it's a double-edged sword. It can add to the infection, but at the same time, it probably prevents fibrosis and recovery from ARDS. Yes, you wish.
My question is that if the patient hemodynamics is stable, in case of Acinetobacter, even the organism, the MDR, do you need to start the colistin or polymyxin? No, if the hemodynamics.
Question is hemodynamically stable, so obviously minocycline is a definitely good choice. It covers the Acinetobacter well and patient is hemodynamically stable. But yes, obviously colistin is always the gold standard for Acinetobacter. But steroid is definitely, this is a double-edged sword, but if patient is hypoxemic, then everybody basically give.
In this patient, the consultant, it was not me, gave a steroid and the patient came out of ventilation, whatever might be the cause. But the general recommendation right now, we have got that DEXA-ARDS trial, where the steroid was used in ARDS patients very early in the treatment. Only then it was successful. The last major trial of late steroid, that's the Lazarus trial, I think. So that did not show any benefit if you start late. But in this patient, the steroid was given and the patient was and came out of. Anyway, all trials don't always they don't tell you the patient, and some physicians are exceptionally lucky. Whatever they do, the patients are saved. So anyone wants to make any other comment? We'll be coming to the end of our session. Anyone wants to make?
In such a situation where you are using so much of antibiotic, we have to use it, and we have to add steroids also. Do we need to add antifungal at that time?
Our practice is that it makes what you call it is a Candida score high. The patient has been sepsis, received so many antibiotics, he adds to one Candida score. If the patient goes into a fresh sepsis, and if you feel the cause of sepsis is not pneumonia, nor UTI, nor maybe a cholecystitis, and possibly a blood stream infection, and you are not growing anything, you are free to use antifungal. But that should be the situation. If a patient has got an ARDS and coming out of ARDS, I don't think you've got much to do. Yeah, if the patient goes into a fresh sepsis, perhaps.
If you look at the Candida score, I think majority of our patients will fill that bracket. And then you have to use an antifungal cover for almost all of our patients, which we don't do. So you have to choose your battles wisely. If the patient is not improving with your conventional antibiotics, send in a culture. Most probably it's going to be Candida glabrata or something like that, and then your antifungals will come into play. But to use a blanket cover, I think it will be an overkill rather than an underkill. Right? Yeah.
Should we chase a Acinetobacter culture report always? Because sometimes the patient is hemodynamically stable and you don't need any anti coverage for Acinetobacter.
No, here the case was that the patient actually worsened, showed signs of pneumonitis and Acinetobacter. Just Acinetobacter without any signs of infection, sepsis, anything, we don't treat. No.
So when patient first presented with ARDS, like is there any role of oxapridil that time in the early ARDS?
Avipladil. Yeah, so I have not used, I am not, anyone has used?
Any of the immunomodulator, the thymosin alpha and all these things, basically it is all in early, and that is a not very robust data are there. Yes, till now people are still battling with that. Is no robust data.
Thank you, sir.
Thank you so much.